hope you had a refreshing tea break and have a chance to explore the dynamic poster presentation. Myself, Elina Khatri, will be hosting this session on behalf of Nepal Health Research Council. It's my pleasure to welcome you all in this 11th National Summit of Health and Population Scientists. We are excited to begin today's session with fresh perspective and inspiring research from across the country. This is a part of our collective effort to advance public health and population science in Nepal. And we are thrilled to have such a passionate and dedicated group of participants, presenters, and guests joining us. We are now ready to begin fifth parallel session of the conference entitled Health Policy and System Research. This session brings together critical reflections and forward-thinking research that inform and shape effective health policies and strengthen the health systems in Nepal. A warm welcome to all our chairs, presenters, participants, and esteemed guests. Thank you for joining us for this important session. We are especially honored to have two distinguished experts joining us as chairs for this session. Now I'd like to take this opportunity to introduce Dr. Laxmi Pathak, a prominent public health leader in Nepal specializing in reproductive health and rights. He had held key positions including Director General of Department of Health Services. Dr. Pathak has made significant contribution to improving Nepal's health infrastructure and services. His work reflects deep commitment to enhancing public health and advancing health policies in Nepal. Dr. Pathak, I kindly request you to take a seat on a dais. Next, it's our pleasure to welcome Dr. Sushil Baral, who had started working in health sector as a community health worker. He is a seasoned health and development expert with over 25 years of experience in research and development. Currently serving at Hard International, Dr. Baral has contributed significantly to the field through his extensive work in health system development project and research initiatives aimed at improving public health outcomes. His expertise spans across various aspects of health and development with a focus on impactful evidence-based solution. Currently affiliated with University of Leeds, Liverpool School of Tropical Medicine, and University of York, UK. He is also an honorary member of Royal Society of Public Health, UK. Dr. Baral, we are truly honored to have you with us. Thank you both for being here. Now with that, I would like to hand over the session to our esteemed chairs. Over to you, chairs.
Namaste. Individually, particularly delighted to be here with my guru, co-chairing this session. Dr. Pathak has been my guru since I appointed in the government of Nepal as a community health worker up in the mountain districts. I've been following his path and sharing today this important session along with him is my pride. Thank you very much for giving me this opportunity. Delighted to have you all here. Welcome once again. Namaste. नेपालमा स्वास्थ्यको नीति प्रणाली अनि त्यसको अनुसन्धान कस्ता विषयहरुमा हामी कहाँ पुग्छौं कुन माध्यमबाट पुग्छौं we have discussed quite a lot a number of sessions 1.5 day wonderful this session is particularly important because we are talking about health policy and system research. These are the buzzwords we hear all the time. Health policy, system, resilient health system, equitable health systems, efficient health systems, health system more adaptive, all these words we have been. I think this session is more on application of those understanding in real world setting by generating contextually tailored evidence that matters most, informing the policy choices, and application of those policies in order to change the behavior as well as the health outcomes. Welcome you all once again, collectively from both of us. I have a request to all the presenter to conclude their talk in 7 minutes, although you allocated 10 minutes. What I've seen in other sessions that we have very limited time to interact with the audience, so we want to have more time. After first, second, third presentation, we will have 10 minutes discussion, and then another 3 presentation, again 10 minutes floor session, and then we'll conclude accordingly. Welcome you all. You can talk either in English or Nepali, as you feel comfortable. Let me invite our first speaker, Amshu Dhakal. Please join us. Amshu Dhakal is a young career researcher, a very eminent public health professional in Amshu, sorry, no, not Amshu. And I'm very delighted to welcome her to give a talk. It's important that we are inspiring young public health career researchers, and she is one of them is standing in front of you. Floor is yours, Amshu. We appreciate if you conclude in 7 minutes.
Thank you for the very nice presentation, respected chairs. Respected chairs and all the research enthusiasts present in the room, Namaste, I am Amshu Dhakal. I am working as a senior research officer at Manmohan Memorial Institute of Health Sciences under Nepal Federal Health System project, and today I am presenting on behalf of this project team on performance of health facility operation and management committees in Nepal, a self-evaluation study. Sorry, is it okay? Before going to the topic I introduced, I would like to introduce the broader research project, which is Impact of Federalization in Nepal's Health System, which was funded by Health System Research Initiative from UK Medical Research Council, FCDO, and Wellcome Trust. And it is a collaborative project from Nepal and UK with various universities like University of Sheffield, University of Huddersfield, Bournemouth University, Canterbury Christchurch University, and from Nepal, 2 institutions such as Manmohan Memorial Institute of Health Sciences and FAISE Nepal. It was started in April 2020 to 2024, and it is a multidisciplinary team expertise involved in the research process. It is a multi-year longitudinal research with a participatory approach, and mixed method approach was used, and the ethical approval was taken from Nepal Health Research Council as well as University of Sheffield, UK. Thank you. Now I'll talk about the broader research question this project identified. What is the impact of federalism of Nepal's health system from federal level down to province level and then to local level? And this research project focused on WHO health system building blocks and the areas of study where each topographical regions representing districts such as Mugu, Kathmandu, Sindhu Palchok, and Navalparasi. And Kathmandu was taken to understand about the urban dynamics. I would like to share 5 priority areas for action which was taken from this project. The first priority area 1 was building capacity for health system planning and management at the local level. And under this, there was a recommended activity that is capacitate local government on health system management, including services, human resource planning, procurement, and finance. And for this, the research team felt the need for assessing health facility operation and management committees' performance. So this today's topic is major focused on this research. And I'd like to talk about the problem statement and rationale of this study, that is HFOMCs were created as the local bodies in 2003 to improve the efficiency and responsiveness of local health system as stated by NHRC and Ministry of Health and Population. With the shift to federalism in 2015, it decentralized the health services, offering many opportunities as well as challenges in local governance, management, and resource allocation. So evaluating HFOMC performance is essential for evidence-based reforms to enhance health outcomes, which was also stated in HFOMC Guideline 2075 given by Government of Nepal. Since many researchers reported that HFOMCs fail challenges like inactivity, political bias, and a focus on infrastructure over service quality, despite being central to decentralized governance, there are very limited evidence on HFOMC functionality across different regions in Nepal. Hence, this study evaluated HFOMC performance through self-reported assessment in diverse ecological and socio-political contexts of Nepal. I would like to show this slide. As we all know about the formation of a committee, that is Health Facility Operation and Management Committee with the 7 core members. This is a very diverse committee. As we all know, there are representatives from business as well as schools, female community health volunteers, the ward representatives, as well as the health facility in charge, and there are also the minority groups such as the disabled people and female representing the committee. So it is a very diverse and strong committee within the local level. Now I'd like to move towards the objective of this research study, that is to assess the performance of HFOMCs based on institutional capacity and committee empowerment, health facility management, and status of health services. And the other objective was to identify their strengths, challenges, and areas of improvement for management of HFOMCs. Talking about the methodology, it is a cross-sectional study. As I have already mentioned, it is a part of broader research project. It was done in late 2023. 2 local areas per district were selected, and 1 urban and 1 rural municipality was selected for the implementation. Representing different topographical regions of our country, that is Himalayan, Hilly, and Tarai. From Tarai, the Lumini province was selected, and under Lumini province, Nawalprasi district was selected, where Rangram and Susta rural municipality was the research area, whereas from Sindhu Palchuk, Chautagra, Sangachok Gadi, and Pachpokhari Thangpal was the research area, and from Mugu district, Chayanath Rara and Mugum Karmarong were the local levels which were included in the study. Now I would like to talk about the data collection and method and analysis. The data collection tool was the Government of Nepal Health Facility Operation and Management Committee guideline. Under this guideline, there is, in Schedule 6, there is a HFOMC self-evaluation tool. And under this, there are 51 indicators assessing various key components such as institutional capacity and committee empowerment, health facility management, and status of health service. This is a self-reported performance of HFOMCs, and it was based on consensus from more than 50% of the HFOMC members. As this tool was designed to ensure the accountability, transparency, and identify gaps in governance and service delivery, descriptive statistics was done. I'd like to move towards the overall findings of this research. That is, overall performance score was 73.9. Nawalprasi West scored the highest, whereas followed by Mugu and Sindhu Palchuk. And among the local levels, Pachpokhari and Mugum Karmarong were the local levels which scored nice performance score. And so from this, we would like to interpret that functionality is not just determined by district level leadership, but it is also strongly influenced by local factors such as governance, resource allocation, resource availability, and the geography. Based on the 3 key components which I discussed earlier, I would like to share about the key strengths and challenges. In institutional capacity and committee empowerment, there was high participation of women and marginalized committees, as well as the meeting attendance was very good. But there were some challenges such as weak transparency, and only 1/4 HFOMCs less than like 1/4 HFOMCs do not hold meetings regularly, as our mandate says that there should be 100% conduction of the meeting. And during, among the health facility management components, strong coordination with local government was there, but there were some operational challenges such as inadequate infrastructure management, development of structured supervision plans, as well as supervision of health staffs and community volunteers. And talking about the status of health service, antenatal care, immunization, iron folic acid supplementation, and family planning commodities, all services were relatively good, but the presence of skilled birth attended during deliveries were very less as reported by HFOMC members. Now I'd like to recommend the major 5 recommendations from this research: that ongoing capacity building to empower local representatives and orient newly elected representatives soon after the election should be done. And the other recommendation is establish the formal systems of monitoring and evaluation of health services as well as human resource for health. The third recommendation is critically analyze and prioritize the budget based on need for the infrastructure development and ensure the complete adherence to HFOMC formation guidelines. And the fifth one is promote transparency by making progress reports publicly available to build community trust and accountability. Since our researchers should share the potential biases of the study, there are site selection bias, as this is the research areas which the project has been implemented. And another is the self-reporting bias, as we have used the government of Nepal self-evaluation tool. I have already shared about the financial support, which is from UK MRC. Now I'd like to conclude. With these 3 important sentences. That is, despite efforts at inclusivity, strong coordination, post-federalization, there is weak governance practices such as irregular meetings, poor transparency, lack of follow-up. So these undermine the HFOMC effectiveness at the local level. Though the self-evaluation format introduces potential bias, but the challenge is highlighted that there is urgent need for attention to prioritize strengthening and sensitizing the health facility operation and management committees at the local level while we are planning for the health local level planning. And committees require both capacity as well as supportive environment to effectively translate intentions to impact. In this way, I'd like to share my acknowledgement to all the HFOMC members and all the health sections of 6 local levels, as well as my Nepal Federal Health System project team, who are watching this virtually as well as in person. And I'd also like to thank NHRC for providing us this opportunity to present our small piece of work. These are my some references. Thank you for your kind attention. Thank you, cheers.
Now I will call upon Simrin Kafle.
Honorable Chair, Co-Chair, respected audience, a very good morning to everyone. I'm Simrin. I'm a PhD candidate at Department of Public Health, RS University, and I'm glad to present one of my research papers entitled, Does Nepal's National Health Insurance Program Protect Against Catastrophic Health Spending? So these are authors, and most of them are my supervisors with an expertise of economics and public health. My whole research paper has a base in this slide where, where I want to show that out of total health expenditures, 54% are paid out of pocket in Nepal. And this is one of the major challenges to achieve universal health coverage, not only in Nepal, but in most of the South Asian countries. And today, I'm talking about catastrophic health expenditure. It's very critical in our country because when households have to spend considerable amount of money on healthcare expenses, they have to compromise their spending on basic commodities like housing, shelter. To address this situation, Government of Nepal has launched National Health Insurance Program in 2016 so that they can protect their citizens from extreme health expenditures. So this study aims to evaluate whether our government has been able to protect their citizens against catastrophic health expenditure. We conducted this study in Pokhara metropolitan city, employing an analytical cross-sectional design with a sample size of 1276, with a 2-stage random sampling. Data was collected face-to-face interviews, and it was conducted in 2023 and 24. So for the calculation of income data, we did it through household spending as a proxy indicator. And for the calculation of household total consumption, we estimated it summing food and non-food consumption, and non-food consumption included healthcare expenditures for the past month. And out-of-pocket related to acute conditions over the past 30 days and chronic conditions or NCDs over the past 12 months were converted into monthly figures, and we aggregated. And healthcare expenditure was based on the self-reported data. It was validated by pertinent documents based on test, treatment, medications. And I just wanted to show some of the bills, how we collected the data. And how did we measure catastrophic health expenditure? It was using the threshold of 10% or more than 10% of total household consumption. And households with the enrollment insurance card was the key independent variable, and household health conditions, socio-demographic characteristics, economic indicators were used as observed confounders. So one of the major features of this research is the use of propensity score matching. Why we used that, I'll be talking about it a bit later, but households were matched 1-to-1 using the nearest neighbor algorithm, and it was based on the propensity scores with a caliper of 0.1. The objective was to ensure close matches, and it resulted in 534 enrolled households to match with 534 non-enrolled households. With that, the enrolled households become 42%. So the propensity score estimates the probability of NHIP enrollment based on household characteristics. It helps to reduce selection bias in observational studies by balancing the differences in baseline characteristics among enrolled and non-enrolled households. A strict tolerance of propensity score matching was imposed to enhance the precision and to ensure high quality matching. And the average treatment effect on the treated was estimated to quantify the effect of insurance effect on CHE. So for the diagnostic test comparison, we did the standardized differences. And variance ratios were calculated. So these are the diagnostic tools, how we ensure the comparability among enrolled and non-enrolled households. So I will not be explaining much on this part, but what about unobserved confounders? The result might be subjected to other hidden bias. So we did Rosenbaum-bound sensitivity analysis to ensure that our findings doesn't get sensitive to other hidden bias. And we tested gamma values and the t-hat. So what are the major findings? Who are getting enrolled? Households with NCDs, households with acute illness, households with elderly members in their family, households with under 5 children. Those who are in more need of health care are getting enrolled in our program. And the interesting finding is that households who are in the poorest wealth quintile, they are least who are enrolled in the program. And this has been depicted through the statistical analysis as well. And this was the reason why we used propensity score matching to address these adverse selection effect. So another table talks about average treatment effect on the treated. This analysis indicated that 3.1 percentage point increase in the likelihood of experiencing CHE among enrolled households. So in total, 9.8% of households experienced catastrophic health expenditure in the last year. And it's very interesting to note that 4% of enrolled households suffered from CHE even though their health expenses were below 100,000 rupees. And I just wanted to share that this sensitivity analysis, we also showed that the p-value was very negligible, so our findings is not subjective to other hidden bias. So this talks about the experiences of enrolled households, and they shared that they couldn't renew the insurance card this year because we can see that it was 16% dropout, and the major challenges faced by them was long waited time and no availability of medicines. And during the data validation, we also, I'm sorry. And during the data validation, we found that not all the prescribed medicines are in generic terms. That means even if the medicine is available at the health facility, but if we do not prescribe generic medicines, they will not get the medicines at the health facility, and they are forced to visit private health sectors, one of the major determinant for high out-of-pocket expenditure. Well, and the most expenditures are on medicines and transportation. I would like to highlight that the very basic medicine, for example, insulin are not included in the insurance program, ambulance, referral transport are not included in the insurance program, and this is one of the major driving forces for CHE. So I would like to conclude this presentation that our National Health Insurance Program provides very limited effectiveness against catastrophic health expenditure. And long waiting times, it could be solved with a digital online appointment system, and the medical shortages, it could be shortages, the real shortages, or could be some other reasons, it should be further digging out. And the benefit package was found to be very insufficient. As I already mentioned, even the diagnostic PET scan machine is, PET scan diagnostics is not included, chemotherapies are not included. And the findings highlight the need for insurance program to expand its coverage, introduce flexible coverage limits based on the income, so that poor also get into the enrollment program, and based on the healthcare needs. If a person is suffering from cancer, and if he has that limit of 100,000, he will die. And the state should take responsibility of this, and I strongly recommend from my findings that government should make strategies to mitigate adverse selection and create a balanced risk pool so that it also provides financial sustainability to the program. So with this, I would like to conclude my sessions. Thank you so much. I'm so sorry for taking longer time.
Pratik Khanal. Pratik Khanal, please. Pratik Khanal is a PhD research fellow, and he has decade of experience in health sector in Nepal.
Good morning, everyone. Namaste. Thank you. Cheers. I'm very honored to be a part of this national conference and discuss a critical topic, that is the impoverishment impact of cancer in Nepal. So going through the background of this study, cancer is responsible for 6.3% of total deaths, that is around 14,000 deaths annually, and 4.3% of total disability adjusted life years. So we know that cancer not only affects the national health system, but also impacts national economies through increased healthcare spending, lost productivity, and rising impoverishment. However, there is a scarcity of comprehensive research on the financial impact of cancer in Nepal. And to address this research gap, this study aims to estimate the impoverishment impact of cancer in Nepal. Now, going to the methods, this was a cross-sectional study conducted in Bhaktapur Cancer Hospital and BP Koirala Memorial Cancer Hospital, Chitwan. Face-to-face interviews were conducted with 353 patients undergoing active cancer treatment, selected purposely. We selected patients with breast, cervical, lung, esophageal, and stomach cancer, as these 5 cancers were the leading cause of deaths in Nepal. Data collection was done in April, May 2024. face-to-face interviews were done, and multivariable logistic regression was done to identify the impoverishment determinants. So now going through the study variables, sociodemographic variables, and then the treatment-related variables, which cover type of cancer, cancer stage during diagnosis, duration of diagnosis, duration of treatment, treatment modality, and receipt in patient care. Similarly, cost of cancer care included information on direct medical cost, direct non-medical cost, indirect cost, which included productivity loss of patients and caretakers, out-of-pocket payment cost, and impoverishment, which is the main interest variable of the study, included calculation of incidence and intensity of impoverishment. Similarly, we also assessed the financial impact of cancer, which included financial coping strategies and consequences of cancer treatment. So the incidence of impoverishment mean the proportion of households that fell below the national poverty line after deducting out-of-pocket spending on cancer from the annual household expenditure. Similarly, the intensity of impoverishment meant comparing the poverty headcounts before and after the out-of-pocket payments. Now let me take you to the findings. The socio-demographic characteristics of the participants. The median age was 56 years. 73% were female, 71% were from urban area. Majority of the participants were from Bagmati, followed by Lumbini and Gandaki. 58.1% had no formal education. The median travel time from the usual residence to the hospital was 300 minutes. And then occupation-wise, 44% were not working in the past 12 months. 21.5% were involved in agriculture, followed by employed and others, including housemaid. Now, regarding the treatment-related characteristics, when we see the duration of diagnosis, more than half of the patients were diagnosed 6 months before. And regarding the treatment stage, 45% were in the early stage and similar proportion were in the advanced stage. 73.4% were undergoing chemotherapy, followed by surgery and radiotherapy, whereas few proportion of the participants were under palliative care. Similarly, 67.7% were in singular treatment modality and 32.3% were in combined treatment modality. 1/3 of the participants had other chronic diseases. 68.8% of the participants were admitted to inpatient care in last year, and 61.8% had prior visit to private health facilities before coming to the study hospital. Now, talking about the membership in social health protection system, we found that 54.7% of the patients were a member of national health insurance. Similarly, 58.6% were member of at least one social health protection scheme, including private insurance. 92.9% had heard about deprived citizen treatment fund, and among those who have heard about the fund, 87.8% had actually utilized it, and among the total patients, 81.6% had utilized the fund. This figure shows the annual cost of cancer care, which is around 4.8 lakhs Nepalese rupees in average per patient. So when we compare across different types of cancer, we find that the stomach cancer incurred the highest treatment cost. Similarly, across different cost categories, annual direct medical costs contributed to around 54% of the total cost, and then productivity loss of patient and caretakers contributed to 31% of the total cost, and then annual direct non-medical cost contributed to around 16% of the total cost. Now let me take you to the cost drivers of cancer care. Higher treatment duration of 6 to 12 months and above 1 year compared to those who had treatment duration of less than 6 months were more likely to face higher cost of cancer care. Similarly, those who were in combined treatment modalities, admitted to inpatient care, and who had prior visits to private health facilities were more likely to incur higher cancer cost. And talking about the catastrophic health expenditure, we found a higher incidence of catastrophic health spending, 96.9% at 10% threshold, and 83.9% at 25% threshold of annual household expenditure. So this figure shows that there is a higher incidence of catastrophic health expenditure among cancer patients. And when we explored the determinants of catastrophic expenditure, we found that treatment duration of 6 to 12 months compared to less than 6 months. those who were admitted to inpatient care, and those who were in the lowest to high wealth quintiles, compared to highest wealth quintiles, were at higher odds of facing catastrophic health expenditure. So this figure shows the impoverishment impact of cancer. On the right side, we can see a figure which is a Penn-Sparrow diagram. The red dotted line is the national poverty line. The blue line is the annual household expenditure of the patients. We can see that majority of the patients fall below the poverty line. There are clear spikes across each income quintile after spending on cancer care. 82.7% of the households were below the poverty line, whereas 56.4% of the households were already below the poverty line before cancer spending. So when we see the impact of cancer, we can see that 26.3% of the households were pushed below the poverty line due to cancer treatment. So even if we include patients only who started their treatment within the last 1 year, we see that 24.3% of the patients were pushed below the poverty line due to cancer treatment. So now when we see that who are at risks of impoverishment due to cancer, then we found that wealth quintile was the only variable which was significantly associated with the impoverishment due to cancer, whereas other variables was not significant, which suggests that the economic status of the patients is a strong determinant of impoverishment due to cancer. We found that patients in the lowest to higher wealth quintile had 39 times higher odds of being impoverished compared to patients in the highest wealth quintile. And then the risks of impoverishment was relatively uniform across any other socio-demographic and treatment-related groups. We saw this that whether patients belong to any socio-demographic groups or any treatment-related groups, they are at risk of impoverishment. So the financial coping strategy, we see that the 83% of households use their household income, 41% use their saving,
And the policymakers should listen very carefully and translating this evidence to the reality. And what you clearly highlighted, the major contributors of catastrophic expenditure is medicine. Looking at the drugs list, essential drug list, and I was shocked yesterday's presentation, only 0.2% health facility at the periphery level have readiness of providing basic healthcare services. That means there is a problem in terms of supplies, readiness, various things. Why? Are they writing more than what the patient should consume? Or these drugs are not available in a public facility? That's why they go to the private sector? Or why it is? What needs to be changed in order to address this gap? That's my question. The questions are, I'll encourage you to very sweet and short response.
Thank you for the question, sir. I'd like to respond that since our sampling unit was HFOMC, not the individual, as HFOMCs involve all diverse group of people, including marginalized communities as the attendees, not in the major core committee, but they are the attendees like the adolescents, the senior citizen, and people from the marginalized communities or representative are the attendees. So there is inclusiveness for the marginalized communities too. So I'd like to address this question in this way. And moving towards ma'am question, since this is the presentation of based on the major findings of the broader research project, we picked up the priority area 1, and under that we have the targeted intervention to capacitate the HFOMCs at the local level. And under this, before capacitating, we thought of assessing their performance, and for this we use Government of Nepal Health Facility Operation and Management Committee tool, which is self-reported by the HFOMCs. So this is what they perceive, or what this is the evaluation result of the evaluation, what they perceive, how they are managing their HFOMCs or health facility at the local level. Thank you. I think I have addressed. Thank you.
There is plenty of time. You can meet during the lunch.
Thank you so much for the wonderful question. I have investigated this issue in detail, though it was not directly related or under the objective of my PhD thesis, but that was really the worrying issue. And I also work as a public health administrator under Gandaki province, under Ministry of Health. So why 98 types of medicines are not available, or why not medicines under the insurance program are available? There are 4 major factors, and I would like to highlight that. The Public Procurement Act and Regulation, which takes at least 6 months to procure basic medicines to ensure its round-the-year availability. How can we make that? The medicines should be procured in a short duration of time, ensuring its quality. And I also want to focus ensuring its quality, because we do not have mechanism to ensure the quality of medicines which we procure on mandatory basis. Maybe people do not trust on our medicines, and they are forced to visit other health facilities whom they trust more. Another is, all the medicines are not under the responsibility of local government. Federal government, provincial government, and local government have different responsibilities to purchase different types of medicines. How will this work? How these 3 tiers of government will coordinate together to buy medicines on what month, how much? This is also one of the major challenges. Another term is that this could be the point of departure for other researchers. What is the demand side and supply side moral hazard? Supply side moral hazard could be that they do not prescribe the medicines in generic terms, and patients will go for branded medicines and they will not find it at the health facility. Another is, what is the demand side hazard? They want medicines for all the conditions. And do we really need it? We have to research on this, and this could be the point of departure for other researchers. Thank you.
Thank you, Simrin. There's quite a lot food for thought and future research as well. And this is a beauty of health policy and system research, I must say. It unfolds the ground reality and really gives a direction for the policy shaping in the country. We have 7 more presenters. Wow. Great. Without any delay, I would like to invite Mr. Bahadur Gurung. Gaz is a health financing expert with a PhD in public health and currently working remotely.
Thank you, Chair. Namaste, Sawailai. So let me begin because I have very short time. I have a privilege to be the second speaker on the similar topics after my fellow speaker, so I can skip some of the things. The only difference between, I think, my topic and her is this was part of my PhD thesis, which includes both out-of-pocket expense and catastrophic health expense. Oops, sorry, technology. Okay, so I won't go very detailed into the background, but just as a supporter of the National Health Insurance Program, I just wanted to recall some of the thoughts from yesterday or the remarks from yesterday, where in particular our National Planning Commission Vice Chair, Honorable Siva Adhikari sir, told that in spite of improved health status in our country, it didn't actually provide the risk protection, the adequate risk protection. And this is where the context and the relevance of health insurance comes into. And this is where we really need to do the assessment whether this health insurance program is really doing its job or not. So straight to the study objective is to evaluate the outcome of the social health insurance programs in improving the financial risk protections, and in particular, in very simple, I just calculated out-of-pocket expense and catastrophic health expense. So I won't go into this. This was, in case I had more time, this was just to familiarize all of you with the National Health Insurance Program, which I may not have to do because we also have a dedicated program tomorrow. So I'm also so this one. So in terms of the methodology, as I mentioned before, so the methodology which I present here is part of the PhD thesis. So it's one part. So I had several parts within this thesis. So this is one quantitative part. And my study design was pre-post intervention with controlled. I really wanted to do randomized, but because of the way the enrollment and the expansion was going on, it was not possible. And also so many other constraints. So the intervention here is the health insurance program. So I didn't create any intervention. The program itself is the intervention with insured and uninsured population as a control. And study area was, again, we did in the same district, coincidentally, in the municipality. It's just the timing difference. I did in, my data collection was before and after COVID. So COVID had an impact in my study. It went on for almost 17 months in between pre and post. And I had a smaller sample size than her. So my 125 pre-post and 125 control. Data analysis, I didn't go into, all the detail, but in summary, so I had to do non-parametric tests, especially to measure the means between two groups, because with the financial data, you can never say what you will kind of receive. So there are lots of highs and lows, and inflation was adjusted because it was 17 months, and COVID cost has to be adjusted, and there are lots of adjustment that has to be made, which I didn't include here. And in terms of the health expense, it was medical, non-medical, opportunity cost, and I categorized the health expense into outpatient, chronic illness, and hospitalization. So straight into the results, I only received 100 responses in post-data survey, but luckily there was no statistical differences between the 100 people who were in the post versus 25 who only did the pre-interventions, and also no statistical differences between intervention and the control group. So the out-of-pocket expenditure was not very conclusive. So if you see, within outpatient, I actually found there was increased one, and I'll explain why there was increased one. But for the chronic and the hospitalization, compared between pre and post, there were some decreased in the hospitalization cost, but it's not statistically significant. So if I compare, compare between interventions and the control group, it was slightly consistent again with the hospitalization cost in terms of the more serious illness. Cost was higher for the control group. And now coming to the catastrophic expense, I mean, she's already done my job in terms of explaining how we calculated that. I used the same. The only difference is I used 4 thresholds: 10%, 20%, 30%, 40%, because while I was doing that, that was a kind of trying to see the equity within different wealth quintiles. So in here, there wasn't anything conclusive, but then within the control group, and also I'm sorry for this graph not having any data point there, but consistently, the control group had more incidents of catastrophic health expense, and this is very clear as well. So so in terms of the pre-post and interventions, interventions versus control, so almost at all the threshold, the incidence at the control group was higher, but again, they were not statistically significant. So in a way, it's slightly contradicted with our findings, but again, this is not conclusive. So there are lots of discussions that has to be done to explain some of these findings. So in terms of the conclusion and the discussion, so I mean, in any time you do this kind of financial analysis, so methodology takes a big difference. You can do the same study in the same locality, I mean, and also in different span of time, you get a very different result unless it's not, nationally represented, and this one has depicted the same thing. And one of the reasons why, what I was about to explain is there was increase in outpatient cost from pre to post. And my data could be just coincidence, but in trend in different other countries as well, actually there is increase, increment in in the first few years, with insurance because of the moral hazards, because of because of the unavailability of all the benefit package, all the services as mentioned by my fellow speakers, and also on the other part of my research, it was the same. The drugs were not available. The prescription of very expensive drugs for the insured people, and they have to buy from their own pockets. But one consistency was, I'll just take 1 more minute. So the only consistency that I found was the hospitalization cost or the more serious cost had some level of it indicated, so it's not conclusive, but it indicated that some level of protection might have been given, and these findings are kind of supportive from the other countries as well. So takeaway message on much. I think our benefit package, we just revised it, but every time, some of these data and evidence are not being able to taken into considerations anytime, every time we do such kind of a revision. And I think it's a high time that Health Insurance Board actually take such data collection into their own system, and also it's a ripe time. So my fourth recommendation, I was very happy because someone was already doing that in the span of other 2 years. It's very high time that all the researchers in this room that we try to do more of this research to help one of this national priority health program. Thank you.
Well, thank you, guys. Please take a seat. Great. I know, guys, for a long time, remember all the conversation that we had along these things. It's a very nice presentation. Thank you very much. Keep your questions noted. We have another eminent personality here, who I have far, opportunity to work together in so many occasions. Milima Dongo. Milima. Again, another public health professionals with experience largely in monitoring, evaluation, learning, and research, and strategy development, knowledge management, capacity, skilled in developing various documents that links to the policy and strategy and implementation plan. Milima, over to you. Your 7 minutes, please.
Thank you, Sushil sir. Thank you, Chair and Co-Chair, for this opportunity. Today I'm going to talk about utilization of printed health education materials on family planning, safe motherhood, and newborn care in Nepal, a bit different from the past topics on health insurance and the catastrophic health expenditures. So I'm going to talk a bit about the softer side of the health system. So talking about the background, so health education materials are cost-effective methods to reach wide range of audience, we all know that, and it is the supplement to the information provided by the health professionals. So in context of Nepal, NHRC, Nepal National Health Education Information and Communication Center, is responsible for health promotion activities through delivery of information and health-related messages, and it has been doing so by supplying health education materials since very long time, but however, the effectiveness and utilization of the materials printed by NHRC is not done yet, so this study focuses on assessing the utilization of printed health education materials, especially on family planning, safe motherhood, and newborn care developed by NHRC. Talking about the specific objectives of the study, so this study assessed the accessibility, availability, utilization of printed health education materials on the aforementioned topics. And we also explored the perception of service clients on use of printed health education materials. We did identify the gaps or areas of improvement in the content and design of the health education materials, especially the printed ones for the family planning, safe motherhood, and newborn care. And we also collected the feedback from the study participants on generating innovative ideas for development of new health education materials. Moving on to methodology, so we conducted this study using qualitative study design. Having said that, we did KII, in-depth interviews, focus group discussion, and the exit client interviews. Convenience sampling was used. We collected data from 3 local levels representing Mountain, Hill, and Tarai, and the health workers and FCSBs along with the clients were selected based on the convenience sampling. Given the interest of time, we did the convenience sampling. So these were the study population: Provincial Ministry Health and Ministry of Health, Provincial Health Directorate, District Health Education Focal Person, local level health coordinators, and also the FCSBs from each Palika, health workers from at least 3 health facilities of the selected local levels, client from the health facilities, and also the mothers group from 1 health facilities of each local level. In this process, we collected data from 3 local levels and 2 provincial, 2 provinces, Bagmati and Madhes. So for the data collection and analysis, we developed interview guidelines and field researchers were trained and monitoring of data collection was done. Interviews were recorded in Nepali, translated in English, themes and quotes were generated, and thematic analysis was done. Moving on to results section, I have categorized the results section based on these headings: distribution, availability, utilization, mitigation, perception, and the areas of improvement and innovative approaches. So talking about the distribution process, the NHRC develops the health education materials, sends it out to district health offices, and then from there, local levels receive the health education materials, and from the local level, it is passed on to health facilities, health workers, and FCSBs. But having said that, this formal channel is not always followed, and whether it be health facilities or health workers from peripheral health facilities, they can bypass the local level and get the materials directly either from district health office, NHRC, or even the provinces if the stocks are available. So talking about the availability and accessibility, so it is very painful to say that the printed health education materials are very inadequate in its supply. So in our study areas, we hardly saw sufficient supply of these health education materials. And the study participants mentioned that before federalization, the availability was abundant, but after federalization, it has become insufficient, especially due to reduced interest of the health workers, as well as the lack of supply from the federal level. And another thing identified was lack of communication and coordination about availability of health education materials. People did not know what kind of health education materials were available. So because of that also, the accessibility was not very good. So also, people mentioned that the health education fund was, the money was used in less critical items and which promoted unavailability, and no proper mechanism to ensure if the printed health education materials were available and accessible to health workers, FCSBs, and target groups. When we asked about the mechanism, how they ensured the availability and accessibility, it was only during the monitoring visit they asked if these materials were available or not. Now moving on to utilization, having said the insufficient availability, where those materials were available, it was seen effective and beneficial and actively used during the client counseling session and monthly mothers group meeting. And the lack of sufficient availability and less interest among health workers and clients contributed to lack of utilization of the health education materials. So we asked how it could be mitigated. So people mentioned that making health workers, FCSBs, and clients aware of the importance of these materials could improve the utilization. And also people mentioned that dedicating focal person with sufficient resource could improve the utilization, accessibility, and availability. And also developing proper channel of distribution of these materials could improve the accessibility and utilization along with availability. And adopting alternative approaches for health education could also mitigate the measures, mitigate the availability and accessibility along with utilization. Talking about the client perception, clients and model group mentioned that these health education materials were very useful, and some even mentioned that if they had not seen those health education materials, they would have given more birth and not ended up just with 5 children. So this was irony. And talking about the areas of improvement, people mentioned that use of more pictures than text would be beneficial, because when we observe the brochures, they are very text heavy. And they also mentioned that larger posters would be effective. And can I get 1 more minute? Yeah. So, and the compilation of information in one place, because of the small brochures, the messages were not reaching out. So they also recommended or provided areas of improvement at compilation of information in one place, and also putting human faces instead of cartoon characters in the health education materials. And they recommended for printing out calendars, and also using the alternative approaches using social media. So talking about the innovative approaches, people suggested developing mobile applications, use of social media, especially Facebook, TikToks, to disseminate the health education materials, and also the SMS services along with caller ringtone. And though the utilization is low, people mentioned that it needs to be continued along with the digital health education material. To conclude, there are major gaps in the availability, accessibility, and use of printed health education materials in Nepal. Therefore, to address these gaps, holistic approach is required, including improved distribution channel, budget allocation, digital innovation, and stakeholder engagement. Yeah, I end up here, and I would like to thank NHEICC for funding this research, and NHRC for providing me the opportunity to lead this research, the TWG members for providing the valuable feedback in the study tools, and NHRC team members for the administrative support, field enumerators, and the study participants for overall success of the story. Thank you.
Next presenter is Mr. Simrin Sharma. He's a research uptake practitioner with a master's in mass communication and development management, specializing in health communication research and translating research evidence into policy, with over 15 years of experience.
Hello. Respected chairs, my fellow presenters and audience in this room. My presentation title is Influence of News Media on Health Policy Making in Nepal, Insights from Journalists and Policymakers. First of all, I would like to acknowledge my co-authors at HOD International. So the name of the co-authors have been displayed in this screen, you can see there. Sorry. Thank you. So let me start with some background. I think all in this hall use media in this or that way in our daily life, whether it's radio, television, online, or social media. So often it is said that media has big influence in our behavior, big influence in the way we think. So they frame the issues, they set agenda in the society, but unfortunately, globally, there is very limited research and evidence that actually tells us, do media really help policy making process? And if you talk about Nepal, the literature are quite scarce. So in this context, so we are interested to know about if the media have influence in the policy making process, what kind of news sources media use to disseminate the news, and what kind of health agenda they prioritize. So this study was the cross-sectional mixed method study, where we employed qualitative and quantitative approach, and we conducted key informant interview with 15 individuals. And the selection criteria for the journalist was the provincial representations, gender, and the nature of the media diversity, and so on. And the policy makers were largely based at the federal level. And for the survey, our total sample size was 480. That also includes the 20% non-response rate. And very interestingly, we got substantial response that stood 525. Our interview took place in between September 2024 to March 2025 based on the topic guide, which was informed by the study objectives and the literatures. And the survey data was conducted between 2020 October to Jan 2025. So in the interest of time, so I'll also skip some slides. You can see here the provincial representation of the participant of the survey, where you can see the large number of respondents were from Bagmati province because there is high concentration of media in Bagmati province. So we found that 8% of total respondents were focused on the health reporting only, and 92% reported in health as well as other topics as well, because we found that media often do not have the specialized health journalists because of the resource constraint. That's why a single reporter, was assigned to report on the health issues as well as other issues as well. And here is the reporting priority of the journalist. So access to health care received the top priority of the journalist. So, and our qualitative interview also highlighted that these involve lack of medicine, treatment delays, and financial hardship, among other. Likewise, infectious disease were also the most covered area. COVID pandemic, dengue, cholera outbreak got significant attention of the journalist. And the sources of the news, so you can see here, the journalists largely use the government report, experts, and designated spokesperson and information officer to get the news for their media reports. And interestingly, we also found that research papers were the least use of news source for their news reports. So let's go to the influence, which is the significant part of our study. So you can see here the experience of the journalist regarding the influence of their news story in the policy-making process. Journalists call news impact samachar prabhav in Nepali to highlight the influence of their news story in the policy-making process. we have come up with different examples of how news report can influence the policy. And one of the typical examples presented by the majority of our respondents, we found that implementation of Tobacco Control and Regulation Act was one of the area where media report influenced the policy making process. So policymakers as well as journalists told us that when you come up with this kind of policy where there is corporate interest and also the political interest, despite the willingness of policymakers, it's very difficult to push the policy into practice and implementations. In these situations, they actually request help from policymakers and from journalists, and we come to know that to implement the provision of this act that obliges the manufacturer to come up with the pictorial health warnings in the cigarette packs. It was very difficult to implement that, and journalists and policymakers formed the informal alliance to push this agenda, and that was successful. So one of the examples frequently presented by both the journalist and policymaker. So introduction of no harm policy in Kathmandu and public hospital improving services after continuous media coverage, allocation of increased budget in health sector by local levels. These were some of the influence which journalists claimed. And another was the initiative against infectious disease, such as awareness on dengue, mosquito control, were also attributed to the media reports for the policy changes at local level. You can see here one of the testimony provided by the journalist who told that policymaker, despite their willingness, they want to make some changes in the policy, but there are some corporate and the political interest they cannot push. At that time, they personally approach to the journalist, they invite the journalist, talk to them, and they request them to reinforce their idea. And when it is publicized, then it is very helpful for them to reinforce this idea in the higher level meeting, and they present media clips as well. So, sorry for some technical error. Excuse me, would you help me, please? It's not moving yet. So, yes, policymakers largely agreed that particularly health news aimed at benefiting public, and they also, presented the example of tobacco control. And as I told earlier, policymakers cite the news, and they also, use the news clip to reinforce their idea and negotiate the policy changes when they attend certain meeting with the higher authority. And policy makers also verify the news informations from their one internal source as well. So my time is over, sir. So would you please give me 1 more minute to just share the conclusion. Okay. So my last slide. So what we found in our study is media shapes health policy discourse. That was quite obvious because we found that the majority of the journalists, large number of journalists, use government reports. So the health reporting was grounded in the credible source of information. That is what we found our study. And another was journalists and policymakers recognize the mutual value, and sometimes they form the coalition between each other to reinforce the public issues or public agenda before making any policies or taking any policy decisions. And another is news impact is real and observable because we have come up with so many examples of how news has impacted the policy making processes and the health interventions and program decisions. And we also came up with some area where there were some gaps in health reporting. For example, news reporting were always not credible, but there were some rooms of the misinformation as well. And strengthening journalist capacity was very vital. So the final takeaway message, what I would like to say is, our study tells to us that policymakers have to meaningfully and purposefully engage the journalist, and mutual collaborations between journalists and policymakers is vital for the uptake of the news to policymaking process. Thank you very much. I'm happy to respond to your queries if you have. Thank you.
next presenter is Bipul Lamichhane. He is a public health professional with over 7 years of experience, specializing in data-driven program and policy development.
Good afternoon, everyone. My name is Bipul Lamichhane. I work at Herd International as a senior research officer. Today, I'll be presenting to you our study that we conducted last year. It's entitled People's Voice Survey in Nepal, Service Users' Confidence, Satisfaction, and Trust in the Health System. So my fellow co-authors and the affiliations is displayed on the board. Without moving into the context, so globally, I'll be switching between Nepali English as I feel comfortable. So globally, users' perspective on health system, confidence, trust data globally comes even more so in low and middle income countries. And these insights, like health system, healthcare use, how much they trust, how confident they are with the health system. They are critical informations to guide the health for guiding health improvements. And also low perceived quality, and low trust, let's say, utilization directly affect also. So I'll be talking to you about the People's Voice Survey. So People's Voice Survey, it's a globally survey. It's designed by Quest Network, comprising of different universities. Basically, it's a phone-based survey that's designed to incorporate people's voices into the measurement of health system performance. It's also a very cost-effective and a quick way of evaluating people's perception. And maintaining People's Voice Survey, it gathers information on confidence, perception of quality, and overall trust. So methodology, so we're trying to measure confidence, quality, trust issues. We're trying to do that. So what we did is, it's two components, mainly qualitative quantitative components. Qualitative side, so the global PVS tools, Nepal context contextualize garera. Cognitive interview garera. We went and tried this tool with different participants, different demographic characteristics. Try garera to see if there were any misinterpretations or misrepresentation. What do you think of this question? How would you have asked me this question if you were to ask me this question more clearly? We eventually made all the changes in the tool until I back translate garera. We checked with if its original essence lose back. So that's what we did to validate the tool. So quantitative component, we use the same tool, and everyone who's above 18 years of age, in Nepal reside, so we're all our respondents. Probability sampling method use 2000 respondents reach kornako lagi. And we used random digit dialing as the sampling process, which I'll be talking in a little more detail in the following slide. So random digit dialing, basically it comprises of two things. It's a random number generation and random number selection. So what we did was, we did a little bit of research. Nepal major telecom providers kun numbers kun prefix pre-identify all those identified prefix 000 देखि 9999 सम्म lowest possible देखि highest possible range create गर्यौं. We ended up with 123 million possible phone numbers. त्यहाँबाट चाहिँ नि हामीले market share हेरेर एनसेल को एनटीसी को र स्मार्ट सेल को त्यही अनुसारले proportionately हामीले चाहिँ sample draw गर्यौं. And we had around 49,331 चाहिँ नि हामीलाई sample चाहिन्छ to complete 2000 interviews भन्ने calculate गरेर randomly हामीले त्यतिवटा sample चाहिँ draw गर्यौं. As you can see on the flow chart, to reach 2010 completed interviews, 44,284 dial. I'm not going to go into details. Total reached calls, active numbers, then it went down to phone whether they meet the eligibility criteria or not. Criteria meet, whether they're interested in interview initiate, initiate, complete. That's how the sample flow chart goes about. अब चाहिँ I'll be sharing with you the results. Given the interest of time, I'll try to move quickly. हामीले चाहिँ नि के सोधेको थियौँ उहाँहरूलाई भन्दाखेरि चाहिँ how confident are you that you're the one for managing your own health, you're the one who's responsible for maintaining your health भन्दाखेरि चाहिँ 69% ले चाहिँ नि very confident भनेर भन्नुभयो अनि there was only 0.7% who said they were not at all confident that their आफ्नो health चाहिँ नि आफ्नो हातमा छ भन्ने कुराहरू भयो जस्तै education पनि association देखियो जस्तै जो those were higher जसको धेरै education थियो they were more confident in managing their health and income group पनि proportional थियो. And we also asked how confident are you to communicate with the provider भन्दाखेरि चाहिँ नि 85.2% ले चाहिँ they were very confident भनेर भन्नुभयो only 0.3 ले चाहिँ I'm not very confident भन्नुभयो so यसमा पनि education चाहिँ नि had a direct relationship in confidence in terms of communicating with the provider. हामीले उहाँहरूलाई do you have a usual place of care जहाँ चाहिँ तपाईँ normally जानुहुन्छ कुनै trusted source of care छ कि छैन भनेर सोद्धाखेरि out of 2,993 ले चाहिँ नि छ I do have a usual place that I go for treatment भनेर भन्नुभयो सबैभन्दा धेरै चाहिँ नि basic health service centers मा जानु हुँदो रहेछ followed by provincial hospitals सबैभन्दा थोरै चाहिँ नि mission hospitals NGO INGO को अन्तर्गत भएको health facilities चाहिँ सबैभन्दा least utilized भनेर आयो. We also asked them to rate the usual place like कसरी rate गर्नुहुन्छ how much would you rate that excellent, good, very good, fair, poor भनेर सोद्धाखेरि चाहिँ नि 39.4% ले मात्रै चाहिँ excellent, very good or good भन्नुभयो. Older individuals ले चाहिँ more positive ratings दिनुभयो and urban resident ले चाहिँ नि more positive rating दिनुभयो. अनि हामीले चाहिँ नि एउटा critical question के पनि सोधेका थियौँ भन्दाखेरि was there an instance जब तपाईलाई health care को जरुरी थियो when you needed attention तपाईले पाउनु भएन you were deprived of care when you needed it त्यस्तो कुनै instance थियो भन्दाखेरि surprisingly 204 जनाले चाहिँ नि थियो भन्नुभयो that's almost 10% ले चाहिँ नि मलाई चाहिएको थियो तर मैले पाइनँ भनेर भन्नु we did ask किन पाउनु भएन के कारणले भन्दाखेरि चाहिँ नि कस्टलाई चाहिँ सबै धेरै जनाले चाहिँ it was cost because of cost हामीले पाएनौँ भन्नुभयो अरूले चाहिँ नि मलाई त्यस्तो सिरियस थिएन अस्पतालै जानुपर्ने जस्तो लागेन त्यही भएर गएन भनेर so there are all these different reasons म सबैमा जान भ्याउँदिनँ so I'll just move on. And we also asked तपाईँ अस्ति recently जानु भएको health facility how likely are you to recommend that to your friend or your family भनेर हामीले सोधेको थियौँ धेरैजनाले चाहिँ 9 to 10 को रेटिङ दिनु भएको छ so 1 भनेको चाहिँ would definitely would not 10 भनेको चाहिँ definitely would recommend थियो 9 to 10 रेटिङ दिने चाहिँ 47.9% हुनुहुन्थ्यो. We also asked them तपाईको treatment गर्दाखेरि in the past 12 months did you experience any medical error डाक्टरले तपाईलाई wrong औषधि दिएको wrong diagnosis गरेको instancesहरु थियो भनेर सोध्दाखेरि पनि almost 3.7% that is 43 out of 2000 ले चाहिँ नि थियो त्यस्तो खालको मैले I did experience medical error भन्नु भएको थियो. जोसँग informal education थियो they reported higher error. Bachelor's degree हरु भएको त्यो भन्दा माथिको education attainment भएकोले पनि higher error report गर्नुभयो अनि richest quintile ले पनि higher error report गर्नुभयो. So confidence rating मा हामीले यो तीनटा critical question पनि सोधेको थियो how confident are you in receiving quality care when you are sick, how confident are you in being able to afford quality care when you are sick, and how confident are you that government considers public opinion while making healthcare decisions भन्ने तीनटा question सोधेको थियौँ. So 1656 out of 2000 ले चाहिँ नि I'm confident भनेर भन्नुभयो. Ability to afford slightly थोरै 1313 ले चाहिँ नि confident in ability to afford भन्नुभयो and 990 ले चाहिँ नि government considers public opinion भनेर report गर्नुभयो. We also asked them health system कस्तो भइरहेछ त how do you think it is भन्दाखेरि चाहिँ नि it's getting better भन्ने चाहिँ 74.7% हुनुहुन्थ्यो it's getting worse भन्ने चाहिँ 7.7% हुनुहुन्थ्यो it's the same खासै केही चेन्ज भएको छैन भने चाहिँ 17.6% हुनुहुन्थ्यो. We also asked them health system कस्तो छ तपाईको evaluation how is it doing भन्दाखेरि चाहिँ नि the system works pretty well अहिले चलि नै रहेछ minor changes भयो भने it would be fine भन्दाखेरि भन्ने चाहिँ नि 23% हुनुहुन्थ्यो. There are some good things in our system, but major changes are necessary. भन्ने चाहिँ 61.6% हुनुहुन्थ्यो and it needs complete rebuild. केही पनि ठीक छैन everything is a disaster भन्ने चाहिँ 14.6% हुनुहुन्थ्यो. We also asked them to rate government or private health facilities like rate गर्न line. So private health facilities as you can see ले चाहिँ slightly better rating पायो government health facilities भन्दाखेरि भन्दा पनि and so moving on to the conclusion, एउटा चाहिँ नि there's demographic disparities in confidence depending on age, gender, where you live, कुन region मा हुनुहुन्छ that was त्यसको चाहिँ effect confidence मा थियो and utilization पनि रुरल रेसिडेन्ट चाहिँ नि मेनली बेसिक हेल्थ सेन्टर्समा अनि प्राइभेटहरू के अरे अर्बन एरियामा चाहिँ नि प्राइभेट हेल्थ फेसिलिटिजहरू चाहिँ नि युटिलाइज गर्ने हामीले पत्ता लाग्यौँ अनि अनि देयर आर मल्टिपल हेल्थ फेसिलिटी एउटा इन्डिभिजुअल एउटा मात्रै भन्दा पनि देयर आर मल्टिपल सोर्सेस अफ हेल्थ फेसिलिटिजहरू युटिलाइज गर्नुहुन्छ भन्ने कुरा हामीले पत्ता लाग्यौँ अनि अघि न एज आई सेड अलरेडी प्राइभेटलाई चाहिँ अलिकति स्लाइटली हायर रेटिङ सो द की टेकअवेज चाहिँ नि एउटा चाहिँ नि हाम्रो मेथड जुन द फोन बेस्ड सर्वे चाहिँ इट्स अ फिजिबल अल्टरनेटिभ टु इन पर्सन सर्वे भन्ने कुरा चाहिँ हामीले वी लर्न एउटा चाहिँ नि वान थिङ आई वुड लाइक टु एउटा टेकअवे मेसेज चाहिँ नि 10% अफ द participants despite of needing healthcare ले चाहिँ नि पाएन that's I think it's something pretty serious and needs to be looked at facility preference को कुराहरू भयो half को चाहिँ नि do they have a specific group of provider on public health facilities चाहिँ नि त्यो मध्ये सबैभन्दा most preferred थियो quality ratings मैले अघि नै पनि भनिहालेँ so strategic recommend चाहिँ नि 2030 universal health UHC हामीले reach गर्नु छ भने चाहिँ नि we have to improve provider skills service availability improve गर्नुपर्छ अनि सानो सानो तिनो कुराले if we can increase trust that would result in better utilization of healthcare services. Thank you very much.
Thank you, people. You can have a seat. भोक लागिरहेछ तपाईँहरूलाई मलाई थाहा छ किनभने मलाई पनि लागिरहेछ हामीसँग केही समय छ अझै प्रेजेन्टेसन 3वटा प्रस्तुतिकरण बाँकी छ 1 2 3 त्यो प्रस्तुतिकरणहरू गर्नुभन्दा अगाडि हामी दुईजनाले सल्लाह गर्दाखेरि फेरि एक राउन्ड प्रश्नको जाउँ बसिराख्दाखेरि अलि बोर लागिराख्यो होला क्यान वी स्ट्यान्ड अप इट फिल्स मच बेटर डजन्ट इट आई मिन जस्ट वेभ योर ह्यान्ड ओके जस्ट 1 2 3 4 ओके जस्ट लाइक दिस डोन्ट हर्ट I'm a person, म त्यसै बसिराख्दाखेरि चाहिँ अलि अप्ठ्यारो लाग्छ भनेको मतलब म चकचके चाहिँ होइन बच्चामा थियो होला तर I like moving and we should be. Thank you very much for cooperating with us. एकदमै क्विक बर्निङ क्वेसन्सहरू हाम्रो प्रेजेन्टरहरू लाई यहाँहरूको तर्फबाट छ भने ओहो कति धेरै हात उठेको आमामा यो बत्तीले एकदम देखिँदो रहेछ Okay.
नमस्ते सबैजनालाई मेरो नाम अम्बिका हाल पब्लिक हेल्थ विद्यार्थी काठमाडौँ मेडिकल कलेज केही प्रश्नहरू छन् स्पेसिफिक प्रेजेन्टरको टपिक वाइजै भन्दाखेरि सजिलो होला गुरुङ सरले प्रेजेन्ट गर्नुभएको चाहिँ मैले खास इन्टरभेन्सनको पोर्सन
एउटा मात्रै राख्दिनु ल
एउटा मात्रै छ सर 3 जना इन्टरभेन्सन के थियो भन्ने कुरा अलिकति खुलाइदिनु भयो भने मेबी त्यो ओभरअल कन्सेप्ट बुझ्न सजिलो हुन्छ जस्तो लाग्यो प्री पोस्ट इन्टरभेन्सन भन्ने चाहिँ इट वाज शार्पली प्रोनाउन्स बट वाट वाज द इन्टरभेन्सन गुरुङ सरको प्रेजेन्टेसनमा चाहिँ हजुरको इन्टरभेन्सन के थियो भने भयो भने अलिकति सजिलो हुन्थ्यो भन्ने कुरा भयो म्यामको प्रेजेन्टेसनमा चाहिँ यु डिस्कस्ड ओभरअल अन इफेक्टिभ बेनिफिसियल थियो भनेर हाउएभर हाउ वाज द्याट डिटरमाइन्ड just being based on a qualitative study, how are we claiming that effective थियो beneficial थियो भन्ने कुरा अलिकति खुलाइदिनु भयो भने एन्ड प्लस हामीले कम्प्लिटली प्रिन्टेड मिडिया छोडेर एपमा जानुपर्छ भनेर भन्नुभयो हो कि इन एडिसन टु इट भन्ने चाहिँ क्लियरिटी अलिकति गरिदिनु भयो भने सजिलो हुन्थ्यो जस्तो लाग्यो अनि रिसर्चको पोर्सन न्युज रिपोर्टरहरूले युज गर्नुभएको छैन भएको थियो वेयर देयर एनी फर्दर प्रोबिङ अन वाइ आर दे नट एबल टु युज दोज रिसर्च पेपर्स एज पार्ट अफ देयर न्युज मेकिङ थ्याङ्क यू
ओके एकदम स्पेसिफिक
थ्याङ्क यू म अर्जुन पौडेल यो हेल्थ एजुकेसन प्रिन्टेड मेटेरियलको जो प्रेजेन्टेसन थियो एक्सिलेन्ट जब आई एप्रिसिएट त्यसमा युटिलाइजेसनको पोर्सन चाहिँ त्यो क्लाइन्टहरूको एफजिटीहरूबाट युटिलाइज छ हामीलाई बेनिफिट छ भन्ने कुरा एक्सप्लोर भएको हो कि अब सर्भिस प्रोभाइडर साइडबाट चाहिँ त्यो आएको भने म त्यसमा चाहिँ म जान्न चाहेँ होइन अर्को ठ्याक्कै अनि अर्को यो हाम्रो न्युज रिपोर्टरको कुरामा चाहिँ उहाँहरूले चाहिँ जस्तै टोबाको लगायतको म पनि त्यसको साथी छु टोबाको लगायतमा चाहिँ मिडिया एजेन्सीहरूको ठुलो सकारात्मक भूमिका चाहिँ छ कहिले कहिले हामीले म एज अ गभर्नमेन्ट अफिसियलको नातालाई पनि मेरो एक्सपिरियन्स पनि के छ कि कहिले कहिले फेरि न्युजलाई नै फेरि त्यो कम्पनीहरूले प्रयोग गरेको पनि त्यस्तो कुराहरू चाहिँ तपाईँको स्टडीमा एक्सप्लोर भयो कि भएन कुनै कुनै अहिले पनि हाम्रो एउटा इस्यु छ म यहाँ सेयर नगरौँ न्युज त्यो कम्पनीहरूले चाहिँ न्युजलाई प्रयोग गरेर हामीलाई काम गर्न गाह्रो भएको पनि मैले फेस गरिरहेको थिएँ यहाँ सेयर नगरौँ त्यो चाहिँ एक्सप्लोर भयो कि भएन स्टडीमा थ्याङ्क यू
मेरो नाम इम साके म चाहिँ प्रोक्योरमेन्ट सप्लाई चेन एक्सपर्ट मेरो 3वटा क्वेसन छ 3टा पहिला म सिरियली जाउँ अम्सुलाई HFOMC को अहिले पनि राम्रै भइरहेको रहेछ होइन तर तपाईँले भन्नुभयो नि अब कतिवटा HFOMC को चाहिँ तपाईँ कति मिटिङ हुँदैन होइन तपाईँको इरेगुलर छ र तपाईँको स्टडीमा चाहिँ HFOMC को कुनै तपाईँको रिसोर्स छ कि एक्सपोर्ट गर्नुको भएन पालिकाले सपोर्ट गर्छ गर्दैन उनीहरूको ब्याङ्क एकाउन्ट हुन्थ्यो पहिला होइन त्यस्तो किसिमको उनीहरूको आफै सस्टेन गर्ने रिसोर्स थियो कि त्यसो एक्सपोर्ट गर्नुभयो कि भएन मेरो एउटा क्वेसन तपाईँलाई भयो अर्को मिनिमाजीलाई चाहिँ तपाईँले भन्नुभयो नि अब तपाईँको यो पोस्टरहरू अनअभाइलेबिलिटी छैन तपाईँको हेल्थ फेसिलिटीमा र तपाईँले स्टडी गर्दाखेरि चाहिँ तपाईँको त्यो कन्सर्न ठाउँको जिल्लामा गएर हेर्नुभयो कि भएन उहाँको स्टोरमा गएर त्यो पोस्टर छ कि छैन अनि त्यो कति कुरा चाहिँ तब जिल्लामा गएर थनिकिरहेको हुन्छ जिल्लाबाट तल जाँदैन त्यो एकदम नजिकै हुन्छ त्यसमा साधारण कोअर्डिनेसनबाट पनि त्यो सल्भ हुन्थ्यो होला तर तपाईँले त्यो एक्सप्लोर गर्नुभएको त्यो एउटा पार्ट हो अर्को मिडियावाला यो लास्ट मिडियावाला चाहिँ तपाईँहरूको अब एकदम राम्रो स्टडी हो तर तपाईँहरूको अब के अरे यो हेर्दाखेरि चाहिँ ओभरअल हेर्दाखेरि चाहिँ टोबाकोमा एकदम हाइलाइट भयो होइन तपाईँको जे कुरा पछि टेक अवे भन्छ नि एउटा तपाईँको टोबाको मात्र भयो पोलिसीमा टोबाको त्यो सबै हामीले बुझेकै कुरा हो तर तपाईँहरूको मिडिया गर्दाखेरि चाहिँ सिमरनजीको उसमा पनि आएको थियो क्वालिटी अफ मेडिसिनमा सोध्नु भयो कि भएन प्रोक्योरमेन्ट डिलेज जो पब्लिक हेल्थ पालिका सबै 753ले प्रोक्योर गर्छ इसेन्सियल मेडिसिनहरू प्रोभिन्स त्यसको डिलेजको कुरा भयो कि भएन क्वालिटी अफ मेडिसिन होइन अलिक ट्रस्टको कुरा छ किन खाँदैनन् त किन गभर्मेन्टको औषधिहरूलाई तपाईँले प्रायोरिटी दिँदैन किन बाहिर किन्छन् त्यस्तो कुरामा एक्सप्लोर गर्नुभयो कि भएन त्यो मेरो क्वेसन
हजुर धन्यवाद हजुर
I'm Dr. Sital Gautam. मेरो 2टा क्वेसन्स छ my first question is to Milima ji. Since you've used
quantitative हामीले यहाँ सुन्न एकदमै अप्ठ्यारो भइरहेछ उहाँहरूले बोलेको प्राविधिक साथीहरू त्यो आवाज चाहिँ प्रष्ट आएको छैन आवाज आएको छ तर प्रष्ट छैन केही हेल्प गर्नुहुन्छ हजुर
Okay, to Milima ji, since you have used qualitative methodology, so what strategies did you use to ensure the trustworthiness of this qualitative data? And another question is to Bipul ji. So could you please describe more about the cognitive interview as a method? Thank you.
Thank you very much. हामी अहिले प्रश्नहरू धेरै छन् यहाँहरूको उत्तर सबै प्रश्नको दिनुपर्छ तर यही मञ्चबाट दिनुपर्छ कि पर्दैन सोच्नु होला फेरि भेटेर नि गर्नु होला टाइमको ख्याल गर्नको लागि मिलिमा when you start
हजुर सबै प्रश्न गर्नेहरूलाई धन्यवाद यो यता म्यामले सोध्नु भएको थियो इफेक्टिभनेस चाहिँ कसरी डिटरमाइन गर्नुभयो भन्ने बारेमा हैन त्यो चाहिँ उहाँहरूलाई नै यो कतिको इफेक्टिभ लागेको छ भनेर जस्तै क्लाइन्टहरूलाई पनि सोधेको थियो भने सर्भिस प्रोभाइडरहरूलाई पनि सोधेको थियो र उहाँहरूकै पर्सपेक्टिभको आधारमा चाहिँ इफेक्टिभनेसलाई डिटरमाइन गरेको हो र यो हेल्थ एजुकेसनको मटेरियल्सहरू चाहिँ एपमा मात्रै गएर मटेरियल्सहरू सबै बन्द गरौँ भन्ने हेतु चाहिँ होइन हैन इन एडिसन टु प्रिन्टेड मटेरियल्स चाहिँ एपहरू पनि डेभलप गर्नुपर्छ किनभने सबैजनालाई प्रिन्टेड मटेरियल्सै चाहिन्छ भन्ने छैन कसैले चाहिँ एपबाट पनि एक्सेस गर्न सक्छ भने चाहिँ उहाँहरूलाई चाहिँ प्रिन्टेड मटेरियल्सको सट्टामा एपबाट पनि गर्न सकिन्छ भन्ने कुरा भयो भने यता सरको क्वेसनमा चाहिँ यो पर्सपेक्टिभ युटिलाइजेसन एक्सेसिबिलिटी सबै चाहिँ सर्भिस प्रोभाइडरको मात्र पनि होइन क्लाइन्ट मात्रको पनि होइन दुवैलाई नै सोधेको थियो र उहाँहरूकोमा चाहिँ आउँदाखेरि कुरा चाहिँ त्यही नै अभाइलेबिलिटी चाहिँ कम छ त्यही भएको भएर चाहिँ अब हामीले कसरी युटिलाइज गर्ने भन्ने कुरा आइरहेको थियो भने हेमसरको कुरामा चाहिँ यो डिस्ट्रिक्टको स्टोरमा गएर हेऱ्यो कि हेरेन भन्ने कुरा थियो कुनै कुनै ठाउँमा चाहिँ लोकल लेभलमै पनि थन्किएको अवस्था थियो भने कुनै चाहिँ हेल्थ एजुकेसन कर्नरमा राखेको छ तर त्यो हेल्थ वर्करले युज नगरेको पनि अवस्था थियो। त्यसको लागि डेफिनेटली कोअर्डिनेसनले चाहिँ हेल्प हुन्छ। र अर्को यता म्यामको क्वेसनमा ट्रस्ट वर्दिनेसको लागि के गर्नुभयो भन्ने कुरा थियो। अघि मैले मेथोडोलोजीमा पनि देखाएको थिएँ होइन, सबै इन्टरभ्युजहरू चाहिँ रेकर्ड पनि गरेको थियो र त्यसलाई चाहिँ जस्ताको तस्तै ट्रान्सक्राइब गरेर त्यसपछि बल्ल ट्रान्सलेट गरेर चाहिँ डेटा एनालिसिस गरेको।
हुन्छ, थ्याङ्क यू मिलिमा तपाईँको रेस्पोन्सको लागि। समयको अलि अभावले गर्दाखेरि म एकदम स्पेसिफिक भएर गएँ।
थ्याङ्क यू सर। सुरु गरौँ के अरे यो जर्नल आर्टिकल्सहरू चाहिँ नि किन एकदमै कम प्रयोग भयो भन्ने सन्दर्भमा। यसमा हाम्रो क्वालिटेटिभ इन्टरभ्यू गर्दाखेरि ल्याक अफ नलेज अबाउट द प्लेटफर्म अफ द जर्नल आर्टिकल्स एन्ड टेक्निकल डिफिकल्टिज टु एक्सेस द जर्नल्स and complexity to interpret the technical issues of journal articles, and they have to focus on the contemporary issues of the country and the event. That's why I mean journal articles were not prioritized भन्ने उहाँहरुको कुरा थियो है। सेकेन्ड चाहिँ नि न्यूज हरुलाई चाहिँ नि कम्पनीले पनि प्रयोग गरेको छ कि भन्ने कुरामा चाहिँ हामीले एथिकल रिपोर्टिङको पार्टबाट केही क्वेशन्सहरु हाम्रो थियो। त्यसमा चाहिँ नि उहाँहरुले के एक्नोलेज गर्नुभएको थियो भन्दाखेरि अनएथिकल रिपोर्टिङ प्र्याक्टिस पनि छ हेल्थ जर्नलिजममा, तर लार्जली जर्नलिजम एथिकल छ र ह्यान्डफुल एकदमै लिमिटेड मिडिया आउटलेटहरूले र जर्नलिस्टहरूले के अनएथिकल प्र्याक्टिस गरेको पनि इक्जाम्पल छ, तर लार्जली वी आर फोकस्ड अन एथिकल रिपोर्टिङ भन्ने थियो। अनि अर्को कुरा चाहिँ टोब्याकोको कुरा हामीले किन गरेको भन्दाखेरि हामीले ओपन क्वेसन्स राखेको थियौँ, हामीले इक्जाम्पलमा फोकस गरेको किनभने हामीसँग पोलिसीलाई इन्फ्लुएन्स गर्छ भन्ने त आम बुझाइ छ। क्यान यु गिभ इक्जाम्पल्स भनेर हामीले त्यसरी एक्सप्लोर गर्दाखेरि पोलिसी मेकर र जर्नलिस्ट सबैले चाहिँ टोब्याकोको इक्जाम्पल दिनुभयो कि, अनि हामीलाई के लाग्यो भन्दाखेरि ओके यो चाहिँ समथिङ ट्यान्जिबल एउटा आउटकम रहेछ कि भन्ने हामीलाई लाग्यो, त्यसलाई हामीले बढी फोकस गरेको हो। अदरवाइज यो नो हर्न पोलिसीको कुरा अनि त्यसपछि लोकल लेभलमा चाहिँ नि एनुअल वर्क प्लान र बजेटमा चाहिँ नि बजेट इन्क्रिज गरेको कुराहरू मिडियाले लेखिसकेपछि लोकल मिडियाहरूले त्यस्तो कुराहरू पनि आएको थियो, धेरै नै इस्युजहरू आएको छ। थ्याङ्क यू।
के अरे मेरो स्टडीमा इन्टरभेन्सन क्वेसन सोध्नु भएको थियो, मैले भनेको थिएँ मेरो इन्टरभेन्सन चाहिँ हेल्थ इन्सुरेन्स प्रोग्राम नै इन्टरभेन्सन थियो। त्यो भएको कारणले प्रीको पार्टिसिपेन्ट्सहरू चाहिँ हु अलरेडी इनरोल तर चाहिँ सर्भिस युटिलाइज गरि नसक्नु भएकोहरूलाई चाहिँ मैले चाहिँ एज अ प्री चाहिँ पार्टिसिपेन्ट चाहिँ लिएको थिएँ। थ्याङ्क यू।
म्यामले कग्निटिभ इन्टरभ्यूको बारेमा सोध्नु भएको थियो। सो हामीले बेसिकली चाहिँ नि जुन ग्लोबल टुल छ त्यसलाई अडप्ट गरेर सुरुमा त हामीले नेपाली र मैथिलीमा ट्रान्सलेट गऱ्यौँ। सो त्यो टुललाई चाहिँ नि हामीले डिफ्रेन्ट क्याटेगोरीको मान्छेहरूसँग लगेर लाइक स्टुडेन्ट अर हाउसवाइफ डिफ्रेन्ट इयर्स डिफ्रेन्ट सोसियो डेमोग्राफिक क्यारेक्टरिस्टिक भएको मान्छेसँग गएर चाहिँ नि त्यो क्वेसन्सहरू चाहिँ नि इच एन्ड एभ्री क्वेसन फ्रम त्यो माथिकोदेखि टप टु बटम सबै क्वेसन चाहिँ नि पढ्न लगाएर या पढेर सुनाएर के बुझ्नुहुन्छ, लाइक कन्करेन्ट थिङ्क अलाउड मेथड भन्छ। सो वी बेसिकली आस्क देम टु भर्बलाइज देयर थट्स। यो पढेर के बुझ्नुभयो, यो सुनेको क्वेसन के बुझ्नुभयो, यसको तपाईँको दिमागमा के आयो, अरू कुनै मिसइन्टरप्रिटेसन भयो कि भएन, यसलाई अझै क्लियरली सोध्नु सकिन्थ्यो कि सकिँदैन भनेर वी वेन्ट एन्ड टक विथ मेनी डिफ्रेन्ट पार्टिसिपेन्ट, सबैजनाको फिडब्याक चाहिँ नि कलेक्ट गरेर द फाइनल टुलमा चाहिँ हामीले इन्कर्पोरेट गरेको। इफ द्याट आन्सर यो क्वेसन।
धन्यवाद। धेरै प्रश्नहरू छन् होला। वी क्यान कन्टिन्यू टु डिस्कस, दिस इज अ प्लेटफर्म वेयर वी क्यान मिट एल्सवेयर। अब हामीसँग 3टा प्रस्तुतिकरण छ। डक्टर प्रतीक्षा ढुङ्गाना अनि फलोड बाई प्रकाश एन्ड धानु। हामी डक्टर प्रतीक्षा ढुङ्गाना आउँदै हुनुहुन्छ। बिडिएस गर्नुभएको छ, मास्टर इन पब्लिक हेल्थ ग्लोबल हेल्थमा मास्टर्स गर्नुभएको छ, एन्ड द फेलोसिप इन हेल्थ इक्विटी, अनि अहिले करेन्टली सर्भिङ एज अ कम्युनिटी हेल्थ लिड। वाउ, द्याट्स a big responsibility you're bearing in health in Naya Health, Nepal, Achamma. Welcome. Over to you, ma'am.
Thank you. Respected Chair, fellow presenters, and the audience.
Amru presenters, Saru, feel free to move to your seat. Thank you.
Health insurance. Sorry, thank you so much. Health insurance is one of the financing mechanisms of health system that can contribute towards universal health coverage. Carefully designed and implemented health insurance program can help increase utilization of health services providers' accountability and competency and reduce out-of-pocket expenditure in healthcare. The National Health Insurance Program and the renewal rate remains low, especially in Assam. Objectives of the study: to assess the facilitation support, especially from the patient navigators and enrollment assistants and community health workers in improving the coverage, to identify the barriers to enrollment and renewal of the health insurance in Assam, and to assess the acceptability, feasibility, adoption, fidelity of the facilitation support. Methodology: a mixed method approach was employed, conducted in 5 rural municipalities of Assam. The study population for the rapid assessment phase with enrollment assistants, patient navigators, community health workers, patient attending at Banalbata Hospital, enrollment officers, mayors, chairpersons, or the health coordinator at the municipalities. For the assessment of the implementation strategy, enrollment assistant, patient navigators, community health workers, and people enrolled and non-enrolled in the insurance. Sampling method: adaptive sampling was used for the qualitative data collection, and convenience sampling was used for qualitative data collection. Sample size: quantitative data, sample meeting criteria during the study period from Feb to April 2024, and qualitative data determined using the saturation technique. For the rapid assessment phase, 8 interviews and 3 focal group discussions were done. In the implementation assessment phase, 20 interviews and 5 focal group discussions were held. And the study duration was from December 2023 to December 23, 2024. And the data collection methods: qualitative, key informant interviews and focal group discussions during both the research stages. Quantitative, semi-structured questionnaire, data collection tool. It was the ComCare, which is a digital tool used in community health program in Assam, and OpenIMS and Nepal EHR's electronic health record system. Data management and analysis: quantitative, descriptive data analysis and SPSS, and qualitative, the thematic data analysis using NVivo. Ethical consideration: written and formed consent was obtained from the participant, secure data storage with restricted access, and ethical approval was obtained from the Nepal Health Research Council. Going in the result, it highlights significant challenges in assessing and maintaining the health insurance coverage among the population in Assam. A substantial gap in identification for health insurance exists, with 7.8% of the surveyed population lacking necessary documentation. This suggests a potential barrier to assessing healthcare services, while a majority of 62.7% have heard about the health insurance. The translation of awareness into coverage is limited. Among those with the proper identification, only 33.3% receive information about obtaining health insurance, indicating a missed opportunity for intervention. Despite this, 37.7% of the household reported having at least one family member enrolled in the health insurance. However, the depth of coverage within this household is inconsistent, with 51.6% having full family coverage and remaining 48.4% with partial coverage. The result further reveals a challenge in maintaining insurance coverage of those with the family members enrolled. 56.9% had active insurance, with 43.1% had inactive policies. A promising aspect is that high percentage, 86.6% of those with inactive coverage received counseling from our community health workers for renewal. However, 76.3% of those counseled agreed to enroll or renew their insurance. However, the process of enrollment faces hurdles, while 72% agreeing to enroll with the referred enrollment assistant. So, in short, total number of total non-insured were 62%, insured in health insurance after counseling were 57%, total insured increased within the 3 months were 5.1%. Acceptability. Initial enthusiasm due to free insurance card for marginalized group and community awareness campaign. Decreased satisfaction over due time due to long waiting times and lack of priority for the insured patient. Poor understanding of the referral processes. Reduced the perceived benefits. Community health workers and local leaders still advocate for the program despite the challenges. Feasibility, financial strain on vulnerable groups, limiting sustained enrollment, lack of train and role assistance causing service gaps, insufficient claiming process and referral system confuse, discourage participation, inconsistent integration between the insurance and the healthcare facilities, reduce perceived usefulness. Systemic barrier. Health facilities do not prioritize insured patients, leading to frustrations among the patients. High turnover of the enrolled assistants, reducing community engagement and continuity. Weak coordination between the stakeholders, community health workers, hospital, insurance offices, affecting the program efficiency. Limited awareness and understanding of the insurance benefits among the community led to underutilization. Conclusion, the health insurance program in Assam has shown early success but faces significant challenges. Strengthening logistic support, including train and role assistance and better communication is crucial for sustainability. Reducing financial barrier can encourage broader participation. Key improvements should focus on minimizing enrollment assistant turnover, streamlining the referral processes, and enhancing the healthcare service delivery. Addressing these challenges can help expand coverage and insurance, ensure timely, accessible healthcare for vulnerable population. Thank you.
Thank you very much. Please take a seat here. हामीसँग अर्को प्रस्तुतकर्ता हुनुहुन्छ Prakash Adhikari. May I invite Prakash Adhikari, who's a Bachelor in Public Health from IIM and currently working as a medical record supervisor in health service in all the way from Delhi. Thank you. हुन्छ तपाईको
Okay. Thank you, sir. Respected chair, fellow presenters, and all the audience, I am Prakash Adhikari, presenting on the topic job satisfaction among local level health workers following federalization in Nepal. Okay. Our research was led by Mr. Ramesh Kaur, who is also the Office Chief of Health Office, Kailali. And moving into the background of this study, if we dig into the impact of decentralization in health, we can see that in high-income countries, we have seen enhanced coverage of health services, reduced mortality rates, increased life expectancy, while in lower middle-income countries, decentralization has mixed effect. We can see that there are improvements in mortality reduction and service delivery. However, there are challenges related to resource availability, equity, and accountability. Considering this, despite the mixed evidence in the literatures, we went under the federalization in 2015 after the implementation of new constitution. Following the federalization, a total of 82.9% of the health employees were adjusted in local level with main responsibility to deliver basic health services. Following this, this adjustment, news such as issues related to employment adjustment were seen in newspapers. For example, we can see there were thousands of cases filed and thousands of applications were filed in MOSP and Ministry of Federal Affairs. And similarly, we can see that there are job salary delays among the local level health workers. And we have to acknowledge that there is high importance of job satisfaction as it influences service quality, efficiency, equity. It also impacts employment, absenteeism, and turnover. Considering this background, our study team went through various literature and found out that there was a big literature research gap And there, none of the studies were examining the job satisfaction level among local level health workers following federalization. In this regard, our study team conducted this study to assess the job satisfaction level and the associated factors among local level health workers in Sudur province. It was a cross-sectional study. It was conducted in local level health workers who were permanently recruited from either Lok Seva or were adjusted post-Employment Adjustment Act 2075. And it was a cross-sectional study with a sample size of 444, and it was conducted in 2023. Moving on to the methodology, we used a 31-item tool ranging from strongly agree to strongly disagree, and marks were provided as -2 to +2, and a mean score was calculated as a mean item score was calculated, and cut-off value was used accordingly. And this tool was pre-tested. It was administered in Nepali language, and there was a high internal consistency with a Cohnberg alpha of 0.88. Moving on to the data collection technique, our data was collected online using self-administered questionnaire, and Google form was used. And we distributed the questionnaire to the messenger group of 9 different districts, and a health coordinator or health officer was designated as the coordinator of this research. Ethical considerations were adhered with the NHRC guideline. Ethical approval was taken from IRC IOM, and the administrative approval was taken from Health Directorate of Sudur province. Moving on to the dependent variable, our major outcome variable was overall job satisfaction, which was measured under 3 different domains. Firstly, the working environment, employment adjustment process and policy, and local governance. Scoring technique was from -2 to +2, and those with less than 0 or 0 were considered as dissatisfied. These are some of the independent variables that were used in our study. And considering the data management, we analyzed the data in SPSS version 25. We firstly conducted a chi-square test. Then those variables which were significant, those variables which showed the p-value of less than 0.1 were entered into logistic regression analysis, and 95% confidence interval was calculated, and those with p-value 0.05 were considered as significant. Following this data analysis process, let me explain some of the general characteristics of the participants. 50.2% of the employees were employed in hilly region, and more than half were working in urban region of the Sudur province. 62.4% of the participants were local resident. 18% were health worker working in health section of municipalities, and 2 in 5 were gazetted officers. Looking at the result, we can see that only 14.9% of the health workers were satisfied at the local level, and only 4.3% were satisfied with the employment adjustment process and policy. Overall, gazetted officers were dissatisfied with their job, and regarding the working environment, those with higher educational attainment, that is more than masters, were lessly satisfied with the working environment. And talking about the local governance, those who were working in the health section of the municipalities were highly satisfied than those working in the peripheral region. And regarding the geographical aspect, those working in the Himalayan regions were highly dissatisfied compared to those working in Tarai or hilly region. I would like to acknowledge some of limitation of our study, as it was an online survey. Those without the access of internet were not excluded in the study, and due to subjective questionnaire, there could be the possibility of respondent bias. And I would like to conclude the study by saying that only a small proportion of health workers are satisfied in the local level, and most of them are not satisfied with their employment adjustment process. Considering this is very high number considered to other lower middle income countries. However, we would suggest that further studies should be conducted to analyze the trend, and qualitative study is also important. And here are some of the recommendations that we would like to give. We need to address health worker concern regarding the adjustment first. Secondly, we need to provide career development opportunities for those serving in deprived areas and challenging workforce. Similarly, offer responsibilities and opportunities aligned with the workers' educational qualification. As highly educated health workers who are seen to be less motivated, we need to offer them more responsibilities aligned with their educational purpose. And we would like to acknowledge Ministry of Social Development and Health Service Directorate. Here are some of the references that we used in our study. And thank you, that's it from my side. I would like to get some questions from you. Thank you.
Next presenter is Ms. Dhanush Vishwakarma. He is a nursing officer at Pokhara Academy of Health Sciences, Western Regional Hospital.
Thank you, respected chair, respected audience. Namaste, it's me, Dhanush Vishwakarma. Today, I am here to present my research study on job satisfaction among school health nurses working in Bagmati province. Talking about background of the study, school health nurse is a dual commitment profession having the concurrent obligation for both healthcare and education. We already know that job satisfaction is key factor influencing the nurse's work performance with a factor such as salary, administrative support, autonomy, and working condition played a significant role. In the USA, 83% were satisfied among the 71 school health nurses. The prevailing requirement and demands placed on school health nurses differ from classic nurse practice, balancing the role strength and role ambiguity onto school nurses, leading to job dissatisfaction. Although there is scant research literature on job satisfaction among school health nurses in Nepal till now. The general objective of this study is to find out the job satisfaction among school health nurses working in Bagmati province. Let's talk about methodology of the study. Descriptive cross-sectional research design was used. All government school of Bagmati province where school health nurses were working is the study setting, and the total number of population was 409 school health nurses, and sample size is 132. Simple random sampling method technique. The Latte method without replacement was used for data collection. Data was collected through an online self-administered questionnaire using an online Google form, prepared in both English and Nepali language. Nurses who had at least 6 months working experience and willing to participate in the study were included. Result. Table number 1 presents the socio-demographic characteristics of respondents, in which 68.9% belong to 22 to 29 years age group with the mean age 27.84, and 89.4% follow Hindu religion, and 58.3% had PCL nursing degree, and 42.4% had equal or more than 3 years working experience as a school health nurses. Table number 2 presents the respondent satisfaction with pay, in which 1 indicate strongly disagree, 2 moderately disagree, 3 neutral or undecided, 4 moderately agree, and 5 strongly agree, and hashtag indicate reverse scoring. In which 62.9% moderately agree with that their salary is satisfactory, and 65.2% strongly agree that there is need for upgrading pay. Regarding the respondent satisfaction with professional status, 43.9% strongly agree that nursing profession choose if they had to make the decision over again, and whereas 66.7% strongly disagree with that the job really doesn't require much skill or knowledge. Regarding the respondent satisfaction with autonomy, in which 65.2% strongly agree that they have sufficient input into their profession, and 31.1% are neutral or undecided about the supervise more closely than necessary, and in which 32.6% moderately agree with that sometimes proceed because all of the activities seem programmed. Regarding the respondent satisfaction with the interaction, in which 45.5% moderately agreed with that teamwork and cooperation between various levels of professional was good, and in which 59.8% strongly agree with that they could have delivered much better care if they had more time with each student, and in which 37.9% strongly disagree with that school administrator looked down on school health nurses. Talk about the responder satisfaction with tax requirement. 48.5% strong, moderately agreed with that they are satisfied with job tax. Regarding the responder satisfaction with organized policy, 33.3% strongly agreed that there is a greater gap between what the nurses need to do and what they are going to do, and in which 37.9% strongly disagree with that sufficient control over and scheduling on shift at Oak Palace. Regarding the responded obtained mean score in job satisfaction related variables, in which highest mean score obtained in tax requirement, followed by professional status, and less mean score is obtained in organizational policy, which is 2.28. This study presents that responded level of job satisfaction, on which 68.2% school health nurses were satisfied with their job, and whereas 31.8% were dissatisfied with job on the basis of mean scale score 19, in which minimum score is 30 and maximum score is 115. Regarding the association between the level of job satisfaction among responded and selected variables, in which representative significant p-value is less than 0.05, and this study indicates that education level of school health nurses showed a significant association with level of job satisfaction. Conclusion. This study concludes that 1/3 of school health nurses are satisfied with their task and profession. Likewise, 1/4 are dissatisfied with organizational policy regarding the lack of opportunity for career advancements. The job satisfaction of nurse tends to be associated with their educational level. Recommendation of this study is, according to finding of study, it can be recommended that government of health policy and school administrator should organize the program and strategy to promote the organizational policy and pay for school health nurses. Talking about acknowledgement, I would like to give my deep gratitude to all the respondents who have participated in the study. This is the reference of the study. Thank you for your attention. Have a good day.
Thank you, Dhanush. You can take your seat, please. Very timely. We go only with burning questions because our stomach is also burning. One, may I request you to be very specific, please? Can't see the lights. Please.
Question is for the first presenter of this among three, which was related with health insurance in Assam. तपाईले प्रेजेन्ट गर्दाखेरि परिवारको सदस्यहरू इन्सुरेन्समा आबद्ध हुनुहुन्थेन भनेर प्रेजेन्ट गरिरहँदाखेरि परिवारको साइज कति थियो र त्यस्तो भयो भन्ने जानकारी छ भने बताइदिनुहुन्छ? धन्यवाद.
Next.
Thank you very much. I'm Dr. Ranjita Detail from UCL, and really brilliant and nice to be here. But mine was more of a kind of okay, it'll be specific but sort of broad. When you were all presenting, I was quite surprised how you didn't talk about theory or framework that kind of influenced and informed your research, and also what evidence was missing, and the reason you did, you kind of designed your research design. Probably that's two questions, but but the other one was I really the information design presentation. I was really interesting, but when we look at information design, like you talked about printed, but engagement with the public and the community was absent. Other disciplines like graphic design, other types of design, iterative design. There's so much in other disciplines. So this goes to all members. Look at other disciplines and what they're doing, what theories that they've used. So this is more of an observation. So you don't have to answer the question now, but something to think about. Thank you.
Thank you very much.
तीनजनालाई एकदमै धन्यवाद. Very powerful presentation. मेरो क्वेसन चाहिँ प्रकाशलाई छ. He is a very nice person, my beloved junior as well. दुईटा पोइन्टमा चाहिँ एउटा चाहिँ प्रश्न छ, एउटा चाहिँ more like no research is a end point. There is always room for improvement, हैन. पहिलो प्रश्न चाहिँ Have you seen any differences between those who were recruited after the promulgation of Constitution and before who were adjusted? There's a job satisfaction among that group, between that group. Yeah? And another is, just for clarification, the research could have been more like improved. If you have some satisfaction score level before the promulgation of Constitution, or like before we were moved into the federal structure, the satisfaction score among those who were adjusted by the government, not recruited after the federal structure, that could have been better. So thank you.
Hazur, thank you very much. Ekdam quick response. Do you have any?
Thank you for the question. I'm delighted to answer the question from one of my beloved senior. And talking about the process, this is the limitation of our study, as we didn't take the data whether they were adjusted or they were newly recruited from Lok Seva. And regarding another question, the suggestion was pretty good. I think if we could have included that, it would have enhanced our research quality. And some of the other limitations were we collected data as a categorical variable rather than continuous variable, which could have been collected as a continuous variable, and it would have enhanced our study also. Thank you so much for the question. Thank you.
म एड गरिहाल्छु उहाँ प्रकाशजीको प्रेजेन्टेसन एकदम रमाइलो लाग्यो हैन, राम्रो छ। ठ्याक्कै यही नै स्टडी भर्खर हामीले पब्लिस गरेका छौँ बीएमजेमा हैन, चितवनमा गरेका थियौँ। त्यसमा चाहिँ तपाईको र हाम्रो एउटा सिमिलर भएछ, त्यो लोकल के अरे हायर एजुकेसन गरेकाहरुमा सेटिस्फ्याक्सन हाम्रोमा लो थियो, तपाईको पनि त्यही आयो। तर हामीले चाहिँ हायर एजुकेसन नहुँदै पनि लोकल्ली रेसिडेन्ट छ भने चाहिँ उसमा चाहिँ फेरि जब सेटिस्फ्याक्सन हायर आएको थियो। त्यस्तो खालकोमा चाहिँ हजुरकोमा स्टडीमा समावेश भएको थियो कि थिएन क्याटेगोराइज गरेर स्टडीमा तपाईले भेरिएबल राख्नुभयो कि राख्नु भएन, एउटा क्वेसन भने। अर्को ठ्याक्कै मेरो यो जबसँग पनि टच भएको विषय, यहाँ स्कुल नर्सको जब सेटिस्फ्याक्सन आयो, म काम गरिरहेको छु त्यही प्रदेशको, र जुन मेरै अफिसले त्यसको ह्यान्डल गरेको भएको भएर पनि मलाई यो कन्सर्नको विषय भयो। स्कुल हेल्थ नर्सको 86% स्कुल हेल्थ नर्स स्किल र नलेज चाहिँ उहाँहरूसँग जे छ त्यो रिक्वायर छैन भन्ने खालको उहाँहरूको एटिच्युड देखियो भने, सेम टाइममा चाहिँ 68%हरू चाहिँ सेटिस्फाइड भएको देखिन्छ। यसले चाहिँ हामीमा के फेस गरिरहेको छ बागमती प्रोभिन्सले भने, जो रिटेन्सनलाई हामीले एकदम च्यालेन्जिङ भइरहेछ। अर्बन एरियामा उहाँहरूको रिटेन्सन राम्रो छ भने बाहिर जाँदाखेरि चाहिँ उहाँलाई हामी काठमाडौँ बाहिर दिल्लीभन्दा बाहिर चाहिँ टिकाउन मुस्किल भइरहेको अवस्थामा यो 86%ले चाहिँ तिनीहरूको जब स्किल र जब नलेज यदि रिक्वायर छैन भन्ने हो भने चाहिँ तपाईको सजेसन के हुन्छ कि हामी शिफ्ट गर्न सक्छौँ त त्योभन्दा लोअर लेभलको उसमा? मेरो सजेसन छ। थ्याङ्क यू।
आई थिङ्क आई हेभ अ क्वेसन, म त्यसको एड्रेस गर्न चाहन्छु। र हजुरले सोधे जस्तै यदि लोकल्ली लोकल नै हो भनेपछि जब सेटिस्फ्याक्सनमा के इम्प्याक्ट परेको हो भन्ने कुराहरू सायद सोध्नु खोज्नुभएको होला। हामीले लोकल रेजिडेन्स हो कि होइन भनेर पनि एउटा भेरिएबल राखेका थियौँ। आउट अफ वेयर अराउन्ड 61% वेयर द लोकल रेजिडेन्स होइन। त्यसमा हामीले दुइटै हेर्दाखेरि पनि लोकल रेजिडेन्स हुँदा र नहुँदामा चाहिँ जब सेटिस्फ्याक्सनमा केही पनि फरक परेन अक्रस अल 3 डोमेन्स। तर एउटा इम्पोर्टेन्ट कुरा चाहिँ के थियो भनेदेखि इम्प्लोइमेन्ट एडजस्टमेन्टमा विच वी कुडन्ट मेन्सन हियर ड्यु टु भेरी लो स्याम्पल साइज, none of the health employees those were adjusted in Himalayan region were satisfied. एकजना पनि सेटिस्फाइड हुनुहुन्थेन हिमालयन रिजनमा एडजस्टेड भएको। त्यो कुराहरू हामीले लजिस्टिक रिग्रेसनमा राख्न सकेनौँ ड्यु टु जिरो त्यो क्याटेगोरिकल भेरिएबल बनाउँदाखेरि एउटा सेलमा जिरो आएका कारणले। बस थ्याङ्क यू।
थ्याङ्क यू फर द क्वेसन। मैले हजुरको क्वेसन राम्रोसँग बुझेको छु भनेदेखि चाहिँ हजुरले फ्यामिली जेरो भइरहेछ, इनरोलमेन्ट जेरो छ, त्यसमा चाहिँ फ्यामिली साइज कति थियो होला त भनेर सोध्नु भएको जस्तो लाग्यो। अब इट डिपेन्ड्स। अछाममा चाहिँ लाइक मोस्ट अफ दि माइग्रेसन रेट एकदम हाई छ, स्पेसली द मेनहरू चाहिँ उहाँहरू चाहिँ इन्डिया जानुहुन्छ एज अ माइग्रेन्ट वर्कर्सहरू। कति फ्यामिलीमा चाहिँ सिङ्गल मदर्स विथ देयर चिल्ड्रेन हुनुहुन्छ, कतिमा चाहिँ हजुरआमा बच्चाहरू लिएर बस्नु भएको हुन्छ होइन। तर मैले चाहिँ अहिले हजुरलाई एक्ज्याक्ट यति नम्बर चाहिँ हुनुहुन्थ्यो फ्यामिलीमा भन्नलाई चाहिँ अलिकति गाह्रो हुन्छ। थ्याङ्क यू।
Thank you so much for question. खासमा यो रिसर्च स्टडीले नै सो गरेको छ एकदमै डिसस्याटिस्फ्याक्सन भनेको अर्गनाइजेसन पोलिसी भनेर देखेको छ। अब यसमा मेरो फर्दर रिकमेन्डेसन भनेको चाहिँ अब एउटा कुरा त स्कुल हेल्थ नर्सेसको जब अहिलेसम्म टेम्पोररी फेजको लागि मात्र रहिरहेको छ, पर्मानेन्ट भनेर करियर एडभान्समेन्ट अरू अपर्च्युनिटी छैन। यो कुरामा हामीले वर्क गर्न सक्यो भने फर्दर इम्प्रुभमेन्ट गर्न सक्छ। र सँगसँगै नेक्स्ट कुरा भनेको पे स्केल पनि अझ फर्दर इम्प्रुभ गर्यो भने स्कुल हेल्थ नर्सलाई चाहिँ अझ बेटर सेटिस्फाई गर्न सकिन्छ भनेर चाहिँ रिसर्च स्टडीलाई सजेस्ट गर्न सकिन्छ। थ्याङ्क यू।
Thank you very much. We are already running out of time. त्यहाँ लाइन बस्नुभन्दा यहाँ कुर्सीमा बसेर सुन्दाखेरि अलि राम्रो हुन्छ जस्तो लाग्यो हामीलाई, त्यही भएर अलिकति बढायौँ। I think all the studies, all the presenters, thank you very much. Brilliant studies and all the young professionals. I really love you guys presenting very nice studies with the brilliant framework. Great. धेरै के देखाएको छ भन्दाखेरि health systems and policy concernsहरू देखिएको छ। धेरै जसो domination चाहिँ health financing perspective को studiesहरूबाट आयो, and there is a big problem. It's immense. IEC मा केही राम्रो भएको जस्तो छ, तर we are adapting a very traditional approach. एकदमै concern त only 14.9% job satisfaction at the local level. Adjustment process को देखि लिएर. All these things really need to be taken at the policy level and to have a better dialogue, better discussion in order to address this issue in the federalized context where the responsibility has been divided across the 3 tiers. एकदमै जरुरी छ भन्ने कुराको कन्क्लुड गर्दै यहाँहरुलाई धन्यवाद दिँदै म मेरो रेस्पेक्टेड चेयरलाई
धन्यवाद। हामी अहिले आउट अफ टाइम छौं, नट भेरी लेट बट लेट। हाम्रो सबभन्दा खुसीको कुरा के छ भने तपाईहरुले अहिले जुन कन्स्टिट्युसनले हामीलाई बेसिक हेल्थ सर्भिसेसको बारेमा फोकस गरेको छ, त्यसलाई फ्री नै दिनुपर्छ र त्यसको कभरेज चाहिँ युनिभर्सल हुनुपर्छ। रिच र अनरिचको बीचमा ग्याप जुन छ त्यो ग्यापलाई भर्नुपर्छ भन्ने आशय हो। त्यसको सेरोफेरोमा तपाईहरुले सर्भिसेसका बारेमा पनि प्रेजेन्टेसन गर्नुभएको छ, युटिलाइजेसनका बारेमा पनि गर्नुभयो, इम्प्याक्ट इकोनोमिक इम्प्याक्टका बारेमा पनि गर्नुभएको छ, स्ट्रक्चर र कम्युनिकेसनको विषयमा पनि गर्नुभएको छ। यो चाहिँ पोलिसी इम्प्याक्टकै कुरा हुन् र पोलिसीमा इनलिस्टेड छन् यी सबै कुराहरू। त्यसैले त्यसको लागि यहाँहरू सबैलाई धेरै धेरै बधाई र धन्यवाद पनि दिन चाहन्छु। र मेरो भनाइ के हो भने अहिले मेरो सजेसन यहाँहरूलाई सजेसन के हो भने जुन तपाईले अहिले रिसर्च गर्नुभयो त्यो रिसर्चमा छुटेका कुराहरू यसलाई फलोअप गरिराख्दा चाहिँ एउटा स्पेशलाइज पनि हुन्थ्यो र पोलिसीमा इम्प्याक्ट पनि पर्थ्यो, गभर्नमेन्टलाई पनि सजिलो हुन्थ्यो जस्तो मलाई लाग्दछ। हरेकको स्टडी त्यतिकै महत्त्वपूर्ण छ, त्यसलाई चाहिँ कन्टिन्यू गरौँ। छुटेका पोइन्ट्स भेरिएबल्सहरू राखेर, जस्तै अहिले क्वेसनहरू पनि उठेका छन्, म सबै उसमा त जान चाहन्न। ती क्वेसनहरूलाई इन्क्लुड गर्ने गरी इन्कर्पोरेट गरेर तपाईहरुले भेरिएबल्सहरू बनाउनु भयो र अगाडि जानुभयो भने यो गभर्नमेन्टलाई नै धेरै सहयोग हुने थियो। र यो भन्दै म छोटकरीमा यति भन्दै म यहाँहरू सबैलाई I would like to congratulate all the presenters for their excellent presentation, and I would like to thank listener also for their patience listening. With this, I conclude the session.
Thank you to all our wonderful presenters for sharing your insightful work with us. To show our appreciation, I now invite our session chairs to present a token of gratitude to each of our presenters. As I call your name, please come forward on the stage to receive your token of love and appreciation. Ms. Amshu Dhakal. Ms. Simrin Kafle. Mr. Bahadur Gurung. Miss Nilima Singh Dongol. Mr. Sriman Sharma. Mr. Bipul Lamichane. Miss Pratiksha Dungana. Mr. Prakash Adhikari. Miss Tanush Vishwakarma. A heartfelt thank you to each of you for your dedication, effort, and commitment to meaningful research. Now I'd like to request, Now I'd like to request all the presenters to join us on the stage for the group photo. आउनुहुन्छ फोटो लिएर उहाँहरू जानुहुन्छ अनि के यहाँ कस्तो भिड भइरहेको अनि ठाउँ अड्दैन कि Thank you. Now I'd like to invite Professor Dr. Ananda Vallabh Joshi on the stage to present a token of appreciation to our session chairs for their invaluable contribution and guidance throughout this session. Thank you, sir. And with that, we conclude this session. Thank you once again to our session chairs, our talented presenters, and each of you in the audience for your active participation and thoughtful engagement. Before we part ways for the day, I am pleased to announce that we will have next session after lunch break at 2 p.m. We look forward to seeing you here. Thank you.